Welcome to episode 223 of the Urology Coding and Reimbursement podcast. I'm your host, Scott Painter, with my co-host, Mark Painter and Dr. Ray Painter. And we want to welcome back special guest, Dr. John Lynn. And Dr. John Lynn is a solo practitioner in Gilbert, Arizona, and the founder of the Thriving Urology Practice Facebook group. And John, will you share a little bit about the Thriving Urology Practice Facebook group before we get started?
Well, if you haven't known about the Thriving Urology Practice Facebook group, you're in the minority, I would say, by now. I like to consider myself a modern-day Robin Hood, if you will. You see, I take from the information rich and I give it to the time-constrained poor, people like our listening audience. And this platform is the easiest way that I can accomplish this task, and it's all for free. And if it's free, I'll take 3. Back to you, Scott.
All right. Yes. Well, thank you for coming on, John. We really appreciate your time, and we look forward to a good episode today. Well, today we want to talk about, and some of you may have noticed that episode 212 we had to take down and take off our site. So we wanted to share a little bit why that happened, and then talk a little bit about the content so we can get that information back up to you. But it was an episode that we recorded with John, and what I'll do is we'll start by just setting the stage, and I'll turn it over to Mark. Do you want to set kind of what happened, and then John, fill in the color?
PRS received a letter from United Healthcare demanding that we remove the episode from our website because it included a recording of one of their medical directors. The medical director was located in the state of Florida, which is a 2-party consent state. There is a legal argument here that we could have gone toe-to-toe with United Healthcare because Colorado and Arizona are both states where there is no 2-party consent requirement. So that's why we put the episode up in the beginning. We felt it was perfectly legal and allowed for you to actually get some insight. But that is one of those things in the legal system where David and Goliath end up spending a lot of money, and it did not seem like it was worth that battle, so we acquiesced. So that's why we took it down. And so we'll give you the information that we had from that episode without the recordings this time.
John, how about your perspective?
Yeah.
What did you receive?
Yeah. So sometimes I think United States is kind of a misnomer. It's like divided states. We have single-party consent recording laws. We have 2-party consent recording laws. Florida happens to be a 2-party consent, and then we are in Arizona and you're in Colorado, we're single-party consent, meaning only one party needs to know if the conversation is being recorded. And there are exceptions to these rules, like if you're in a public setting, that doesn't apply. If you are being threatened, then you can record surreptitiously. But in this situation, what the lawyers obtained by Optum are asserting, or she's asserting, is that I broke the law by recording without the medical director's consent. And like Mark said, we can fight it, but it would cost a lot of energy, if you will, resources. To what end? So I do apologize for the sponsor of episode number 212, to your sponsors, episode 212, that episode is not being kept up. But I think in the interest of everyone involved, we would just go over the concepts without the recording and go from there. So I have several thoughts regarding this. Number one, I'm really, really glad that this podcast is so popular that Optum is actually listening to what we are saying. So if Optum is listening, I think everyone should. So United Healthcare is listening. And the other thing is, as soon as the episode drops, you should listen to it, because sometimes it gets taken down. I mean, the first time it's ever happened, so you should listen to it right away. And if you want more of this information, unfiltered, you should consider attending the Urology Advanced Coding and Reimbursement seminar. So anyway, I think the other thought I have is that Optum should consider managing their house better than worrying about what their medical directors is saying in a, I guess, you can say that this type of a Teams type of a meeting, how private is it? So anyway, they should worry more about Change Healthcare and stuff like that than worrying about a little podcast like ours. And what are they afraid of, really? What are they afraid of?
It's a good question.
Yeah.
I mean, in the end, we were passing on information that we received from them that we would consider official because it came from a medical director. So I don't know. Maybe they're maybe they're afraid that their policies are not, they have to be written instead of verbal. Who knows exactly where they fall in place, but they obviously felt that this did not cast United in the light that they wanted to see.
And, I hate to say this, it's tragic and it's unacceptable to have Brian Thompson literally assassinated. That is definitely not acceptable. However, that said, on social media, in private Facebook groups, on Reddit, the vitriol, the hatred, the disdain for United Healthcare is unmistakable. I would say no tears were shed in those comments. And there's a reason why that is the case.
Yeah, the obvious behavior or misbehavior of the insurance companies and what they're trying to do. And maybe it's not what they're trying to do, but the way they're going about it is clearly not productive for the patients as beneficiaries of those individual insurance companies and for the physicians. We've always said that most of the laws and the regulations are out there made for a very small group of people, those people who cheat. Ultimately, the way a lot of these regulations come out, it is so built towards that end that it's impossible to get people the care they really need in a timely manner. And that needs to be fixed. That has to be addressed. So we're certainly, I think all of us are hoping that somewhere down the road, somehow, that we see a change in the way that these individuals set their rules up and execute what they're trying to do, and stop playing the games that are really slowing down and costing the system more money. And some patients, it's costing them significant time, maybe even their lives, with the way that these rules are in place. And that's got to be fixed.
Yeah, even among the physician forums and also in the non-physician forums, the signal, the rhetoric, the sentiment are pretty much universal. The disdain for what the insurance company is doing, especially United Healthcare. And some of the things that I was thinking, what are some of the things that they're doing? Well, if I submit a claim to United Healthcare for taking care of one of their insureds, a lot of times they'll automatically downcode my claim. Or they'll say, well, we'll need more information. Great. We send more information. They'll say, we lost it. And so that requires more work to get paid for just crazy reasons. Those are just some of the things. And also, if you get an authorization to do a procedure and you say you do a slightly different procedure that uses a different code, that means you have to contact them within a very short period of time, or else your claim is denied, meaning I just work for free. These are just, what benefit is that to the patient or us? It's beneficial to the insurance company. Now they can say, you know what, you didn't get a prior authorization within 24 hours, 48 hours, 36 hours, we can deny your claim. It's just basically putting up hurdles to provide care, to want to take care of their insured.
Yeah. And I think I want to reiterate, none of us feel that the actions that were taken against the CEO, that assassination of the CEO, was right in any way. It is completely unacceptable that happened. And our thoughts go out to his family. I mean, that was a man with kids, and he was actually a very smart and very nice guy. I mean, I met him a couple of times, and that was not a fate that he deserved.
I agree.
And that's so that has to be, on record, that is not an acceptable approach. Now, and we know, I'll say, after talking to a couple of the folks from United after this happened, that they from their side are under pressure from their ERISA plans and from everyone else as they manage things to save money. At the same time, they're taking 20% profit and doing very well in that marketplace. So there's got to be a better way, and we need to keep working with these groups, and we need to keep acting as a group to pressure for these changes that will make healthcare better. So it's a dual-edged sword as we talk about this, in that it's a tragedy that this happened. And at the same time, it's definitely a tragedy in many ways, not at the same scale by any means, that we are having to deal with these unreasonable hurdles to actually get patients care and to be paid appropriately for that care.
And the thing is, you all have been teaching the right information, how to apply this information, the coding rules, to your claims, to the care of the patient. And when you're doing things correctly and yet still you're being punished, it's extremely frustrating.
Yeah, it is.
So true. All right, John, why don't we set the stage of what that call was and how you got to actually have a phone call with the medical director and what you were discussing on that call.
So this actually was a call set up. This is actually the third call with the folks at Optum and United Healthcare. And by the way, during that podcast, 212, we did not mention their name. So anyway, during their, so now they ousted themselves. Great. We'll talk about it. They were downcoding a urologist when he was doing vasectomy, undesired fertility evaluation, and taking care of another problem at the same time. So he was billing a level 4, and they were downcoding it to level 3. And the discussion was why level 4 is warranted, especially when he's taking care of a chronic problem, not a treatment goal, and at the same time performing a vasectomy, which carries a moderate risk. So you have a level 4 problem and a level 4 risk. We're trying to share this information with the folks at Optum, and that's why the discussion took place. Initially, that first initial phone call, initial meeting, it was a Teams meeting. Initial meeting was about, well, how are you justifying? Well, first of all, they were debating whether that undesired fertility new patient evaluation was a level 2 or 3. So that was the first meeting. Took care of that. We were able to convince them that it was actually a level 3. And then the automatic downcoding was the second call. And I remember vividly that I was in the middle of the Mediterranean. I was so grateful for Starlink to be able to connect to the Teams call. And I was able to build a convincing case that this urologist was actually correct in his billing. Well, their coders retreated, and on the third meeting, they brought out the big gun, which is the medical director. And that's where we were.
Yeah.
And we were able to get him to concede that if we had appropriate documentation, our reasoning is correct in that if you took care of a chronic problem, not a treatment goal, and did a vasectomy on the same day, that's a level 4 visit. Right. But then there's a fourth meeting, right, Mark?
Yeah. And that fourth meeting, they decided not to listen to us.
Yeah.
I mean, would be the short version of this. They really hung their hat on the fact that the chronic problem at treatment, that not a treatment goal that was being addressed, was not fully being managed, and therefore didn't count. There were other ways to report that. And so they essentially threw it out the window, as a urologist is essentially not somebody who would treat chronic obesity. I mean, that's kind of what the way my interpretation came down. Um, and we were arguing that, of course, that if the treatment or if the documentation were improved, that would constitute a visit, and they basically said no, they didn't think so. And so that's where they ended the call very abruptly, that they weren't going to accept that.
Yeah, it was another coder who was not there at the previous meetings. She just pretty much came in and just railroaded all the progress, all the discussion that we had before. So that was that was it. That was an interesting call to have someone who just doesn't listen to reasoning and just had her own agenda and wanted to just shut everything down, but not really following the CPT guidelines. So that's the other frustration.
Yeah,
with
it was definitely frustrating. It was, I mean, essentially, we make the rules, and this is the rule we're making on this one.
Well, in a sense, they're correct. He who holds the gold makes the rules. And the folks, and the folks who are listening to this, you need to remember that. Whether you're employed in an employed model, whether you are working with a third party, or you are working directly with the patient, a cash pay practice. So he who holds the gold makes the rules. Always keep that in mind.
And it's interesting when you look at that, what you're talking about. If you set look at the patient goal in that scenario, it's typically a patient that doesn't go to the doctor very often because they're healthy, young, and in their 30s, pretty much, maybe do a routine healthcare, but they may not go very often or very frequently at this point in their life. So to have a doc talk about obesity, I mean, that could make a very logical argument that that's very helpful to the patient. So
yeah, even though they're possibly rejecting my claims, I'm still going to talk to the patients about their obesity, especially if they're coming in. Typically, these young guys in their 30s with obesity, morbid obesity, certainly overweight all the time. Over 70% of us are either overweight or obese in the United States. So it's a huge problem across the board. Also, if I see a patient with significant systolic and, more importantly, significant diastolic hypertension when they come in for their procedure, I'm going to address that. So does that mean, I'm a urologist, I can't address hypertension, I can't talk about lifestyle changes, I can't talk about dietary changes, I can't talk about, hey, maybe you want to see a primary care doctor, or hey, maybe I want to refer you to a cardiologist right away. They don't want me to do that? To care of the patient? No, that's ridiculous. But in a similar vein, that's what they're saying.
They are certainly incentivizing you not to do that, with the way they're remunerating you. And then, of course, there's the medical legal risks on both sides of not addressing that, as well as addressing that and addressing it appropriately. And that is not being recognized properly, by the actual actions that they're making as far as making those decisions and payment. So they're really trying to say, cut it down to a couple of minutes, make that visit very quick and efficient, and address only certain things because that's what we're going to pay you for, which is not the incentives we want. I mean, in the end, you're right, John. I mean, these folks need to have those issues addressed. And most physicians that I know are going to talk to the patients about those issues. I mean, it does affect urologic performance and urologic issues, and it is all connected. So it doesn't make logical sense the way they're doing it, but that is the decision they're making. It's a purely economic decision in the face of clinical care, that really should be encouraged.
let's tell our listening audience, what's the takeaway from this? You're a practice that does vasectomies. What are the key takeaway points, and what should you do given the information that we've shared on this episode and that we have?
So I think for taking away from this, that United Healthcare is gonna most likely, and I won't say every time, but they are most likely going to consider a level 3 in front of a vasectomy as probably the highest level that should be billed. I would not be surprised if they start pushing to go back to level 2, given some of what came in that conversation. That is what you need to consider when you're looking at or treating patients with United Healthcare. I still think that, as we have always encouraged you, that you should document accurately what you do. And if you evaluate and manage a chronic problem, you should bill appropriately. You may be downcoded or denied, and that's something that you're going to have to gauge with your own practice as to how much you want to argue with that, how much that processing is, and ultimately how you're going to behave based on that individual payer's activities. But in the end, if you truly do the evaluation and you document well what your management position is relative to any disease state that patient has. Again, I'm going to encourage you to bill appropriately and ultimately then make those decisions based on the individual payer as to how you're going to react.
So that was your recommendation for United and all other payers? Is that just your same recommendation, blanket recommendation?
It's the same for all payers. I mean, it's a chess game, right? I mean, you have to understand the game. Like, some places you don't have to call for prior authorization, like traditional Medicare. Some you do. It's the process that you have to go through as you plan your business and how you actually execute the provision of care and the reporting of that care. So it does apply to all payers, but also understand that every payer in this market needs to be essentially treated a little bit differently in how you go about or how you make your final decisions and what your business focus is going to be, what your resource commitment is going to be to actually get paid for all the activities that you do that are supported by your accurate documentation.
Oh,
And
Scott,
John, how would you document that that visit that you're describing here?
So, Scott, let me go back to the previous point that you were making about taking care of these patients with chronic problems like obesity, hypertension. I've had a lot of patients whom I sent away because of their uncontrolled hypertension. I said, you need to get this taken care of first before I will do an elective vasectomy on you. And many of these guys have come back and told me that, hey, thank you so much for saving my life. I didn't know that I had uncontrolled hypertension. There's a reason why it's called a silent killer. Same thing with obesity and overweight. Addressing that initially and then subsequent follow-up when he was undergoing the vasectomy procedure, many of them have told me, hey, you know what, I listened to what you said. Thanks for addressing that. Nobody's ever mentioned it. And I lost 7 pounds or I lost 10 pounds. So these are small incremental progress that we can make just being a provider, but being a person caring about the patient. So I think it's the right thing to do. I'm going to continue doing it. As far as documentation for your vasectomy, unfortunately it's a 99203 typically if you follow the CPT guidelines, despite what some of the private payers will try to push you to do, just asserting their mandate. Again, he who holds the goal makes the rules. They're saying that, well, we're not going to follow CPT. We're just going to say this is a 99202 or whatever it may be. But if you're doing it correctly, according to the rules, it's a 99203. For the prototypical healthy 36-year-old guy with undesired fertility, you see the patient and you recommend X, Y, or Z vasectomy because that problem is an acute uncomplicated problem, which is a level 3 problem. Data is probably nothing, which gives you a 2, and then risk, vasectomy is a level 4 risk, a moderate risk procedure. Certainly is higher risk than a cystoscopy or diagnostic endoscopy, which is a level 4 moderate risk. So you have a 3 and a 4, that gives you a 3, 99203. As far as documentation goes, When it comes to coding and billing, you don't really need all that history and the physical examination, et cetera, from a billing perspective. And I always emphasize this, from a billing perspective, you do not need all the minutia. That said, from a medical legal perspective, you should definitely document everything related to the patient. For instance, weight, height, blood pressure for me, and past medical surgical history, prior surgeries to the scrotum would be really important to know. Any allergies to medications, pretty much everything that you would record for appropriate patient care. And then, of course, you would go through the appropriate informed consent process. And I say informed consent process because it is not just a piece of paper that you hand the patient. You need to make sure that he understands this is a permanent sterilization procedure. There are other options. Talk about the other options. And if he's not happy with the other options, then this could be an option for him, vasectomy. So all of that needs to be documented. And if you're addressing if you're addressing obesity, overweight, may want to talk about, hey, what are things that are hindering his progress? What is causing him to overeat possibly? Is he just simply not exercising? Or most of my patients will tell me, well, after our last child, I was eating like my wife, so I gained weight. So those are some of the things that you will want to address and document in your chart about what was going on, in addition to the things that you would recommend for the patient and also the implications of continued obesity and overweight, including but not limited to hypertension, stroke, diabetes, heart attacks, joint issues, and increased risk of urolithiasis, kidney stones. So all of that needs to be documented. And for the folks who are actually in the trenches, obviously dot phrases and shortcuts and templates will help you with that documentation.
Excellent.
And like Mark said, different payer rules will require you to do things differently and may pay you at a different level. So that's the other frustration. You're trying to do the best job that you can, but then you have to play these games. And I hate to say this, those who know the rules and play the games the best are usually the happiest.
So true. Ray, your thoughts?
Well, to back up what John said, knowledge is power, and it always feels good to have the power. And I think when you're dealing with the additional issue like obesity, kind of the rule I think makes sense is if you are handling that problem at that encounter and you document it, you count it. Like John mentioned, handling the young obese individual. On the other hand, if you say you're obese and you need to see your primary care doc, then you should not count that as an additional. So if you're handling the problem at that encounter is one thing, but if you're referring it, it's another.
And agree, Pop. That is the evaluation and management part of the evaluation and management codes. Right. Good point. Yep.
Now, on a second thought, going back to a discussion I was having earlier about all of these speed bumps they put in our being paid and the ERISA programs and so forth, I'll restate some history that I have talked about before. Back in many years ago, I was on a national advisory committee for United Healthcare. Yeah, it was sort of like having a fox in the hen house, but it was a unique set of circumstances that put me there. And there was a discussion because back when United really became popular, well, popular from a financial standpoint, not from a doctor's standpoint. They were having, Bill McGuire was the CEO, and they did not have prior authorization, where a lot of the other payers did. So the discussion came up that they had to implement prior authorization because they were losing ERISA contracts. The ERISA contracts is where United manages the health care of a company, but the company is responsible for paying the health care. United is just paid as a manager, not as an insurance. And they were losing contracts. And we tried, I tried very hard to convince them that, doing prior authorization is kind of dumb. What you need to do is use your data and flag the individuals that are abusing the system, but not put a speed bump in front of everybody else. They didn't listen. But the follow-up is they saved hundreds of millions of dollars in their next few years by implementing prior authorization. And in so many ways, and a lot of it we finally determined is docs just did not want to put up the hassle to do it. So in those cases, patients may not have gotten the care they needed. And when I call it a speed bump, we studied that from the state of Colorado pretty intently through a court order. And we proved that you could get any procedure approved if you just knew the right answers to their questions.
The questions that they're asking.
The questions they were asking.
Yeah.
So there was no denying care if you're willing to put all the efforts into doing to providing them with the answers to their questions on why you want to do it.
Yeah, but then you run the risk of falsifying medical records because you may be saying things that are not true for the patient just to get the procedure covered, and I'm not willing to do that.
Well, at that point in time, that was not the case. The questions they were asking. Now, that may have changed over the years. I haven't been involved directly with the prior authorization in years. But at that point in time, that was not the case. If there was a medical necessity for doing that case, then if you played the game, you could get it approved. And you did not have to falsify any records.
Yeah, medical necessity has become a little nebulous from the perspective of the payer.
And it's still a ridiculous thing that it's a product of our capitalistic system, which has gotten a little over the hill.
Yeah, close to 25% of GDP annually.
Oof.
It's going to be a very difficult thing to turn around. So I think I think of this as, wow, what can we do? What can we do to help shape the future of healthcare? It's frustrating. And I think for now, if you want to play the game, you better know the rules.
Very, very true.
And just a fun fact, about 5 years into the program, after they had really implemented the prior authorization and really turned the company more into saving money and making money, I was asked to address the CEO and the board of trustees on how physicians felt about United Healthcare, because I was the only practicing physician on the physician advisory committee. And so I told the board and the CEO that night that physicians looked at the big five insurance company as the evil empire. And United was Darth Vader of the empire.
We just need a Luke Skywalker to destroy the Death Star.
That's right.
We do indeed. And yeah, I mean, it is one of those areas where I think, as we've kind of approached all this, we try and help you understand how to play by the rules. And it is difficult not to play the game that is being laid out in front of you for your financial survival. And not, and in some cases, understand that the rules are not going to be interpreted appropriately by everybody. So we need to keep fighting the fight to make the changes. And yeah, it is difficult to figure out exactly how we're going to come to grips or actually make those changes long term. So the chess game continues, and unfortunately, in the financial side of this is a game, when in reality, the care that you're providing is not a game. Those are people's lives that you're trying to improve or save, and balancing the game in the background with the actual care that you're providing is tough. And I think that's one of the things that contributes a lot to physician burnout is, you've got two different pressures every day, every encounter.
Speaking of physician burnout and also the final rule that came out, a 2.83% decrease in the conversion factor. Do you have any insight on the recent continuing resolution regarding a 2.5% bump, which would net 0.33% decrease, and also any changes to telemedicine?
So the budget resolution to keep the government open included both of those, a 2.5% bump and continued or the extension of the PHE rules for telehealth until 2026, which would be awesome. And unfortunately, yesterday, Elon Musk on X decided that this was a bad bill, went on a rant, and the incoming president actually echoed that sentiment that this budget bill was criminal, and so now it's very much in jeopardy. With threats to primary any Republican that crosses the line to vote for this. So we'll have to see how this goes. I mean, the battle continues, and our deadline is tomorrow. So whether or not they're going to be able to actually hold the coalition together that actually negotiated this compromise over several months, with the pressure from a couple of individuals, we'll have to see.
Why did they oppose it, Mark?
Oh, actually, it's been interesting as I've read through some of this, and this has all happened recently. So
I was going to say we're recording this on December 19th, just for context.
Yeah, and so
2024.
as I read through some of this, there are several things that apparently Musk attacked that are not necessarily true within the budget bill. One of the things he posted was that this budget bill included funding for the new stadium for the Commanders, which apparently, again, according to the sources I read, is not actually a part of it. The bill says is that the control of the stadium funding should be done, put in the hands of the city, and it explicitly prohibits federal funding for the stadium. But apparently Musk felt that when he read it, that it was getting funded. There are a few other things that are there. And of course, the overall push is that, I read as well that apparently they'd like to see the budget ceiling increased within this bill, and that is not in there. And so that's, a question. Of course, some people are saying it's because Trump would rather pin that on Biden, but that's politics back and forth, and everything that's there. But ultimately, there were a few other specifics that Elon Musk went after, like biolaboratories and a few things that he called out that looked like misinterpretations of what the budget was, according to the sources that I read. But I think the overall push is that this is an increase in spending, and they want to cut down the spending of the federal government, which is part of their edict as they went in, is that there's too much government and we need to cut back government. So they may have messed around a little bit with the individual issues and the stuff that they're kind of highlighting for the support that they're trying to garner to kill this bill. I think the overall push is they feel it's too much government, too much money.
Hence,
Well, hopefully they'll get it figured out
yeah,
by
hence,
tomorrow. by Saturday, I think the government shutdown date is.
yeah, hence DOGE, Department of Government Efficiency, which I think is an oxymoron, government efficiency. But in any case, a lot of people may not understand that this is a packaged bill, continuing resolution, and in order to pass this, they need concessions from different people. So you have the budget ceiling, you have a lot of different things rolled into this one bill. And it's not just, oh, we're just going to pass telemedicine. We're just going to pass something else specific to Medicare, like 2.5% increase. It's a lot of things packaged into one, sometimes poison pill, if you will. You either take it or you lose everything. And that's the problem. So it's not just telemedicine bad or
Right.
2.5% bad. It's just everything else. Everybody has to agree with everything else contained within some of these pork barrel projects.
So
It is
then-
it is tough.
and it should be pointed out that it's all sides that are trying to grab and work for their own constituents, and that's the messiness of democracy as part of this process, and trying to figure out what is what and who goes where, and ultimately we do have a system in which the government has a huge place within healthcare, efficient or not. It drives a lot of the money and a lot of the decision-making process that is our healthcare system. And we rely on Medicare, and we've seen this a number of times with new technology coming in. If Medicare decides to cover it, then everybody else tends to follow suit. So, there's the pluses and minuses of the entire system that we have in place that we have to deal with, and that's where we are.
All right. Let's wrap this episode up here and get some final thoughts. First, I want to thank John for joining us again on this episode. Much appreciated. Really appreciate your insights and joining us on the podcast. It's always great to have you on as a guest. Thank you. Second thing I want to mention is we want to thank ModMed for supporting this episode. If you're in the market for an EHR or a practice management system, you can go to modmed.com/PRS network for specials for our listening audience. And we also want to thank everybody for listening and being a part of this podcast. It's you all that make it, and we do appreciate that. All right, let's go around the horn. We'll get some final thoughts. Let's start with Mark, then we'll go to Ray and give the final word to John. Mark, final thoughts.
So, I mean, as always, I'm gonna stick with the fight the good fight, document well, provide good care, and then make your financial decisions based on the activities of the players in this game. That's kind of the system we're up against. I would also say that, ultimately, as far as what we can do, if we can rally the troops at this point in time with the late dates to actually support the continuation of telehealth and the actual mitigation of the 2.83% decrease, you should do that. And that's, encourage your patients to call if you want to call, and make sure that you make your points that we need this. This is part of the system. This is part of healthcare that really needs to be taken care of. It cannot happen. Healthcare cannot happen in the way that it is right now without these tools. We need them all. So that would be my short wrap up for today.
Ray, final thoughts.
Well, we've talked today about a lot of things that go on in healthcare and getting paid that we have no control over. But we do have control over how we learn, how we document, and how we bill. So there's really no excuse for a doc not to become knowledgeable about the basic rules. Because if you don't know the basic rules, you don't know when they are bending the rules. So we encourage everyone to learn the basics so we can fight the fight. And you're fighting not only for your pay, but you're fighting for your patients when you're fighting for health care. and the payers.
Great point. And you do mention learning the rules. And John had mentioned this earlier. We do have a seminar coming up in New Orleans, January 31st and February 1st in 2025. John, Mark, and Marianne DeSoyce will be our presenters. We had a great seminar in Las Vegas last 2 weeks ago, and we do encourage you all to join us there. If you go to the episode page, prsnetwork.com/223 for episode 223, there are links to sign up for that. All right, John, final word to you.
To say that I'm a beneficiary of all this knowledge through you guys, PRS Network, over the decades that I've been in practice, it would be an understatement. I started with, believe it or not, Larry Carmichael. He was a pharma rep, I think, who introduced me to evaluation and management. And now here I am on sharing the stage with you and be able to spread this good information. And I just want to remind everyone that it is not, you don't have to despair. If you understand how the system is set up and you understand the rules of the game, you can win. I'm a living example. I'm living beyond the American dream. And part of that is by understanding the rules under which I must practice when it comes to coding, billing, and taking care of patients in the field of urology. So you don't have to despair. There are people who are thriving and doing extremely well. And you have to understand how the rules are set up in this crazy system of healthcare in the United States. So make sure you get the knowledge, understand these rules, and as Scott said, as I had mentioned earlier, consider attending the Urology Advanced Coding and Reimbursement Seminar, where we discuss topics like this in much more detail. In addition, the discussion between the sessions is where you will get a lot of knowledge and power. This is the type of meeting where the water cooler conversations actually get carried out during the meeting. So you will learn a lot of information that will definitely. As a matter of fact, I had a urologist. He always sits on the front row on the left side in Vegas, and he said, after learning a simple thing where he was under coding and evaluation and management, he said, "John, after all these years, I've been under coding." So attending, not just once, but for me, when I was in the audience, I had to attend multiple years just to finally get all the concepts, because you're getting a lot of information during these meetings, during the Urology Advanced Coding and Reimbursement Seminar. So for me, I had to listen many times for the light bulb to come on. But the bottom line is, it is definitely worth your while. You should consider it, and I believe it comes with a money-back guarantee.
Yes, it does. Well, once again, thank you, John. And that's all we have for today. Take us out, John.
As always, thank you very much for the privilege of your time. Please take care of yourself and each other. Most importantly, happy coding.